Good evening, everyone. After the two exhaustive modules, this is basically the third module of the day. So, and it is on special features. So, this special features topic was purposefully kept to address those issues which we have not discussed in the previous modules. So basically in special features, we will address issues like genetic counseling, which we hardly see in majority of the medical oncology conferences. And we will see how realistic is precision oncology, can it be brought to real world practice, and how do we really do a risk communication, whether it was genetic risk or whether it is other risks in oncology. Well, if you look into the genetic mutation, we all know we can get any disease or cancer to be specific. Either we are born with a problem or we acquired the problem over a period of time. So if I'm born with a problem, so the mutation basically starts right before the birth, right from the first fertilized egg, and it goes on, and uh, uh, it gets multiple, it gets it affects basically each and every cell of the body. That is what we call as a germline mutation. Right from the germ cells, goes on to a gestation, and then to infancy and childhood, and the whole uh, cell lines are affected right from the birth. Whereas this is in contrast to a somatic mutation where uh, it doesn't happen from birth. We are not born with it, but we acquire it over a period of time. So therefore, somatic mutation is not seen in each and every part of the cell. It is seen in only affected organs or affected cell lines. So that is the difference between germline and somatic. Germline is we are born with it, and somatic is we acquire as the time goes. So it makes logical to think that if you have a germline mutation, it is usually familial, because germ cells usually transmit to offsprings, and then to siblings, and that's how it goes. So basically, all these germline mutations have a family history of some cancers and relatives, and the defect is in every part of the body. Therefore, we usually see multiple primary tumors, breast cancer, ovarian cancer, colon cancer in an individual, because the whole system is defective. And of course, if we are born with a defect, and we are going to manifest it quite early. So these are the three hallmark features of a germline mutation versus a somatic mutation, where it is early in onset, multiple primary tumors, and family history of same cancers and relatives. And this is present from birth, this is present in all cells in the body, and it is present right from the germ cell itself. So what are the usual manifestations of germline mutation? We have recognized some associations of germline mutation, what we call as hereditary breast ovarian cancer, which can happen with a BRCA1 or a BRCA2 mutation or a P53 mutation. And then we have colon endometrial cancer, which we see with HNPCC or the Lynch syndrome. And then we have the famous Men syndromes. And these conglomeration or this grouping of organs like breast, ovary, colon, endometrium, multiple endocrine happen with different defective genes, and this usually happens by what is known as Mendelian inheritance, and the inheritance is basically in an autosomal dominant type. So if you have an autosomal dominant inheritance, the chances of the sibling, the chances of the children getting it is nearly 50%. So so that is about Mendelian inheritance. So there is what is called mosaicism. Usually the genetic makeup of all the cells is similar to that of the germline cells, the germ cells, but it can differ in what is known as mosaicism, which is a rare entity. So if you look into the germline mutation or the familial or the hereditary cancers, it's 5% in colorectal, nearly 10% in breast cancers, and 20% in ovarian cancers. So this is some illustration of how an autosomal dominant inheritance happens, what you can see is if one of the parent is affected, the chances of children getting is nearly 50%, and so on. So if you have a circle, it's a female, a square is a male. Uh, if the box or the circle is completely shaded, that means uh, that particular individual carries the deleterious mutation. And if you can point out an arrow, then we call it as an index case, or to specifically say it is a proband. So we give the terminology for a proband. And you can come to the right side of the representation, where you have the proband who is female, who carries a deleterious genetic mutation, and her brother has a deleterious mutation, but has not yet had phenotypic manifestations, or has not got expression of disease in him. And similarly, her father also had a similar deleterious mutation, but it did not manifest in the patient. So this difference exists. So each offspring carries a 50% chance of inheriting mutation in a autosomal dominant inheritance. So this is a wonderful representation of what we mean by each part. Like a square shaded, a circle shaded means what, and if you put an arrow mark, what it means. What if we have a dot in a circle, what it means, as I've already explained. So this is a wonderful representation of three generation family of the genetic chart. So I would like to bring your attention to this chart. So you can see the arrow mark there. This is the proband or the index case. Basically, it's a female. Uh, she's a 41-year female, and the left upper shading is breast cancer. So she was diagnosed with breast cancer at the age of 32. And she had a T1N0M0, which was strongly hormone receptor positive, and she is alive up to age 41. And if you look in upwards, so her mother also was diagnosed with ovarian cancer at the age of 48, but she expired at 52 years. That's what it means. Whereas the proband or the index case sister, who is 39 years age, has not got the deleterious mutation, or she has not got any disease also. So if you look into the maternal grandmother, she was 52 years when she died, and she had a cancer which was not known which cancer it was. So then if you look into the mother's, the proband's mother's sister, she was diagnosed with a breast cancer at 42 and an ovarian cancer at 61 years, and she's alive up to now. So with these pictorial representation, we can understand uh, what cancer it was, what was the age at which they got the disease, and uh, whether they're alive or not, and what type of inheritance it is. All these we can basically understand. Then going further, so if you look into hereditary breast ovarian cancers, uh, if you have a family history of a mother or a sibling with a breast or ovarian cancer, there is significantly increases with high relative risk of breast cancer and ovarian cancer in comparison to the general population. And other cancers are also at an increased risk, like melanoma, pancreatic cancer, and prostate cancer. So the culprit genes with the HBOC mainly is the BRCA1 and the BRCA2 gene. And what is important is these genes have a high penetration. Penetration is the proportion of mutation carriers who develop disease. That is, what is the chance if the patient has a deleterious mutation will manifest a disease. That is what we call as penetrance. So penetrance is age and gender specific. That is, these two factors influence whether the genetic defect should be expressed or not. For example, if you take a male patient, the male patient doesn't have an endometrium, doesn't have a uterus or ovaries. Therefore, inherently the male doesn't manifest with a endometrial or ovarian cancer. Yet even the breast cancer incidence is less in a male. So it is gender predisposition strongly exists, and gender has influence on the expression or penetrance of this genetic defect. And of course, age is another important factor. So the chance or the conversion to phenotypic, that is the penetrance, is high in the younger age when compared to the elder age. You can see both the left and the right uh, pictorial representations, where in the left you can see the incidence of breast cancer is so high in carriers versus non-carriers. For example, you can see in a non-carrier, the breast cancer risk increases at the age of 40 years, and it slowly goes up, and it's maximum around 20% at the age of 80 years. Whereas when a patient has a deleterious BRCA1 mutation, then you can see the risk increases right from 30 years, and it goes on and on, increasing exponentially up to nearly 60% more lifetime risk. So that's quite significant, and it happens early, and it goes on and on in a log fashion, and the risk increases. You look into the right part of the figure, where uh, the patient has a BRCA2 mutation, carrier versus non-carrier. Uh, the community incidence of ovarian cancer is less than 1%. So we don't expect ovarian cancer to be that common. Whereas if you have a BRCA2 mutation, you can see the incidence goes up to 20%, and it starts at around 40, 45 years, and it goes up to 20% lifetime risk. So this is some rough pictorial representation of a difference in the risk or the chance of penetrance in a BRCA carrier versus a normal patient or normal population. Again, this similar thing has been expressed. Breast and ovarian cancer, you can see early age onset exponential increase in BRCA1 versus BRCA2. What you can note is in BRCA2 carriers, the incidence of ovarian cancer is quite low when compared to BRCA1. So this is what we spoke of hereditary breast ovarian cancer. Now coming on to colon cancer, we call what is the HNPCC, hereditary non-polyposis colorectal cancer, or the Lynch syndrome. Here what we see is colon, endometrium, ovarian cancer. Rarely we have small bowel, biliary, ureter, and renal pelvis in brain cancer. So what we usually see is the endometrial cancer, ovarian and colon cancer. Predisposition is there, and you can see the mismatch repair genes being defective. The MLH1, MSH2, MSH6, PMS2, and the EpCAM1. Uh, these they have the manifestation of microsatellite instability in the uh, biopsy or the tumor samples, and the again the penetrance here also is age and gender related. So I would ask you to look into the right part of the diagram, where if you look into the extracolonic cancers in the HNPCC, endometrial cancer has the highest penetration, where nearly 27 to 71%, nearly more than 50% patients will develop endometrial cancer at some point of time if a patient has an HNPCC. Whereas the ovarian cancer, small bowel, urinary tract, gastric are significantly less when compared to the endometrial cancer. So there is, even though there is an underlying genetic defect, we don't see it converted to clinical manifestation, or what we call as penetrance is not equal with all type of cancers. So endometrial being the highest as far as extracolonic manifestation is concerned, hence it is gender dependent. And if you look into the left part of the figure, you can see nearly 75% patients with colorectal cancer is sporadic, that is they acquire once they are born. In the rest 25%, you can see 20% are familial, but they are not hereditary. In the sense, they are not monogenic inheritance in 20% patients. And only in 5% patients we see monogenic or Mendelian inheritance, where a single gene is responsible For example, in 1% we have familial adenomatous polyposis in 1%, and then 5% we see HNPCC being there, that is the Lynch syndrome. So you can see the graph here, the lowest most curve going on, that is the risk in the general population, which is so less than 1%. If you look into the middle one here, it is HNPCC, it is sort of a moderate risk, and lifetime risk is nearly 50 to 60% of colon cancer. And if you look into the APC, or the familial adenomatous polyposis, it is early and the lifetime risk is more than 80%. So this is the pictorial representation of how Mendelian or monogenic inheritance reflects or manifests clinically, and that is what we call as penetrance. So what we can understand is differential penetrance as far as the age and gender of the patient. So going further, why should we do these molecular tests? We can identify the organ at risk, we can identify the gene, we can have risk reduction strategies, and we can avoid treatment which are deleterious, like TP53 mutation. Not only it is beneficial for the patient, it's also beneficial for the relatives in the form of counseling them, reassuring if the mutation is absent, and some primary prevention in the future offspring, that is what we call as pre-gestational or prenatal diagnosis, or that is diagnosing the mutation even before the child is born. So this is the difference between a Mendelian and a multigene inheritance. The before slide I showed you colon cancer, 75% are sporadic, the rest 20% are familial, but they are multigene inheritant. So what is the difference? If you look into the monogenic or the genetic inheritance, the penetrance is significantly high, and we can easily find these mutations by doing specific genetic analysis. Whereas if it is a multigenic inheritance, there are multiple genes, we cannot point out to this single gene that is responsible for it, and the penetrance is significantly less. So doing a genetic testing or a genetic panel testing for a multigenic inheritance or a familial inheritance that doesn't follow a Mendelian principle is futile, because we cannot recognize or we cannot point out that this is the gene that is responsible. So we need to do genetic testing only when there is a Mendelian inheritance, but not when there is a multigenic inheritance. So again, the same thing, what was shown here is being pictorially represented. If it's hereditary or a monogenic inheritance, the penetrance is very high, and you can easily pick up by doing genetic tests. Whereas if it is familial, then of course there is a risk higher than the general population, but the penetrance is low, and you cannot pick up many genes by a genetic testing. Therefore, we must reserve genetic testing for those patients where we have a monoallelic or a Mendelian type of inheritance, that is autosomal dominant inheritance. So the same thing that has been shown, familial versus sporadic versus hereditary. You can see the bottommost line, that is the general population, a line just higher up is the colon cancer in the familial. Yes, there is an increased risk, but not that significant. And then you can go on to HNPCC, and then you can go up to APC or the FAP mutation. So these are the 4 common causes with 4 different penetrance or 4 different risk factors over a period of time. The highest penetrance is with APC, and the highest risk factor for developing colon cancer lifetime. And then comes HNPCC, and then comes familial, and then we have the general population. So again, age has an effect on familial. If the cancer develops early age, then the risk of developing cancer exponentially increases, whereas if the cancer starts in a later age, the penetrance becomes less. So penetrance higher in the early age and low when they start developing in the later age. So this is just to represent the characteristics of a familial inheritance. What you can note in this is you can note here a 59-year-old lady diagnosed with left breast cancer at 58 years of age, and she had her mother diagnosed with breast cancer. So either her siblings or none of her second or third generation uh, uh, have developed any cancer, only her mother and she. So here the risk is slightly higher than the general population, but it is not following the classical Mendelian inheritance. So this is familial, but this is not monoallelic, or this is not Mendelian type of inheritance. So it is very unlikely we'll pick up any mutation by doing a comprehensive genetic testing. Therefore, if we do a Mendelian, if we do a genetic testing, it is unlikely we'll pick up any mutation. So familial, again, also age has an effect on the familial inheritance, where early age onset, higher the risk of developing cancer. So age has an issue with familial inheritance also. So when to do genetic testing, we should do genetic testing only when we suspect a near Mendelian or a Mendelian type of inheritance. If it is a multigenic or non-Mendelian inheritance, it is unlikely genetic testing is going to help. So in an affected cancer patient with suspected Mendelian risk, we can do multiple cancer genes next generation sequencing. Supposing we have a breast cancer patient who also has an ovarian cancer in her mother, or a breast cancer in her sibling, then we have to look into the patient, and we have to do a multi-gene panel testing to pick up BRCA1, BRCA2, TP53, and other mutations, including CHEK2 and all that. So if we identify BRCA mutation or BRCA1 gene mutation in this proband or in this particular patient, what I would want to look into her siblings or into her children is not the extended panel. I will do a specific test which I have picked up in the proband. So I will first do broad panel testing for the proband or for the index patient, and for her relatives I will do a specific test which I have picked up in the proband. There is no point doing a multi-gene testing again and again for all her relatives. So this is what is VUS, which is making a lot of noise in the genetic literature. So we do NGS and we pick up a mutation, and we don't know what it is. We don't have case reports. We don't know what is its penetrance. So this is what we call as variant of uncertain clinical significance. And by repeated reporting and observation over a period of time, a VUS may become significant. Therefore, a VUS today may not be of undetermined significance tomorrow. So we need to go on checking and update, seeing the update whether do we have any answer for a VUS which we have picked up. If we have picked up a mutation which we don't know what the relevance is, then we cannot completely discard it. We have to explain the patient that we don't have level 1 evidence to say that it really turns out to be cancer, but however, we need to periodically check what this VUS means at all for this particular patient. So there's a issue with the penetrance as far as different mutations are concerned. For example, if we have a BRCA mutation, the penetrance is significant. We can see the chance of developing breast cancer is above 60%. Whereas if you have a PALB2 or a CHEK2 mutation, the risk doesn't go that high. So if I have a patient with BRCA mutation, I'll say the chance of getting, the lifetime risk of getting breast cancer is above 60%, whereas a CHEK2 mutation, if it is present, the lifetime risk is not that high. You can see that it is less than 20 to 30% if I have a CHEK2 mutation. But again, if a BRCA mutation is absent in a sibling or in any patient, that means I can say that the risk is almost back to normal to that of general population. But similarly, if a CHEK2 mutation is not detected, they don't come back to the risk of general population. Still, they will have a higher risk of developing breast cancer. So these CHEK2 and PALB2 are like, if you pick up the mutation, they are not at that high risk of penetrance. And if you do not pick up, they do not come back to the normal risk. So this is a very good pictorial representation of what we actually mean by a first, second, and third generation family. So you can see the patient named 0. is the index or the proband patient. Anybody directly related to the patient becomes a first generation. For example, patient's child or a patient's sibling or a patient's parents, they are all first generation. Whereas a patient's sibling's child becomes a second generation because there is one indirect link in between the two. Similarly, if you take a patient's parent's parent becomes a second generation. So how many people are involved in between is what decides uh, 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 what generation they are. So you look into the patient's parents, siblings, child is a third generation. So this is how we say that a sibling is a first generation, parent is a first generation, grandparent becomes second generation, child of the sibling becomes a second generation, a cousin brother or cousin sister becomes a third generation. So this is the representation of a genetic testing pathway. I don't routinely test genes, a multi-gene panel testing or a BRCA testing routinely just like a CBC and a LFT. Before testing, we need to follow the sequence. First, I need to pick up, yes, this is a patient who has a suspected Mendelian inheritance. If that is so, a personal and family history, then I will make them go through what is known as a pre-test genetic counseling, where I'll put the family tree and then I'll inform the patient about the outcomes of the genetic test, and then I'll get a consent signed. And then if I do the genetic test, I will draw two separate samples to look for DNA analysis. And then after I get the test, I will reveal the results of the test. And not only what is the influence on her, I also have to explain what is the influence on the family members. The psychological support becomes immensely important at every level because it has extensive influence on the outlook of a patient towards herself and towards her family. So what do we basically say in a pretest counseling? We inform and empower the patient who's already got cancer. She's already got cancer, basically. Uh, we need to say what is the likelihood that she will carry a mutation. In case of an autosomal dominant inheritance, it is a 50% chance. If at all, if there is a mutation, what is the penetrance of that mutation? For example, if BRCA1 is present, what is the lifetime risk of developing ovarian cancer? What is the lifetime risk of developing a breast cancer? And if I have detected, what are the measures I can undergo, like a risk reduction surgery or a monitoring with mammography and MRI breast? And what are the medications we have, like PARP inhibitors in this patient? So if the test shows a mutation, what difference it makes to my family, that also has to be explained. That again, the risk of family getting is 50%. And we also need to explain the differential penetrance of different organ cancers with that particular genes. So this is an illustration of a pretest counseling. We had a 32-year-old lady who is nulliparous. She is a strongly hormone positive, BRCA mutation positive. Then I would say her that there's an increased risk of second primary cancer, increased risk of ovarian cancer, and the chance of pregnancy are reduced. If she has a TNBC, then the risk that she gets a second primary is much faster, and again it can hamper the risk of pregnancy. So I have to explain this before I do a genetic test for this particular patient. So what if I have a patient who has a very strong family history. Patient has a breast cancer, her sibling has a ovarian cancer, her parent has both breast and ovarian cancer. There's a very strong family history, but I'm repeatedly getting negative result. So what are the chances? Chances that it can be false negative in 10% patients. It can be due to environmental influence, or it can be a sporadic breast, but it is very unlikely to have a phenocopy where it is altered due to environmental influence if there is a ovarian cancer. So if there is negative result, either we assume that it was a false negative or it is a phenocopy. In either case, we have to take her as high risk and ask her to go through whatever high risk protocol she has to go, in spite of not finding a deleterious mutation in this patient. So if there is no mutation phenocopy, we can say that it is due to an environmental influence. And what if we get a negative report? So if gene panel doesn't show any mutation, yes, you have to be happy. We can say that it was just a sporadic one. She doesn't have a higher risk of second primary, but and the familial predisposition is not hereditary, therefore the penetrance is low. Uh, uh, what we have to explain her that negative result doesn't mean that she will not get another cancer, or her siblings or relatives are not at a higher risk. The risk is not zero, it is in par with the general population. And we also have to explain that there are certain familial cancers which are multigenic, which do not follow Mendelian inheritance. So in these, we also have to alert her regarding these familial transmission where the penetrance is low, the risk is low, but higher than that of the general population. So confront negative result with family history. If there is strong family history of repeated ovarian breast cancer, then we have to take it as high risk and treat like a high risk. If there is no such family history, we can take it as sporadic or assume multi-gene inheritance. So the result, if it is positive, then yes, monogenic inheritance, and we have to take it as a high risk. If it is negative, uh, uh, then it can be either then it can be either sporadic where it is true negative, it can be false negative in 10% patients, or it can be familial. If there is a strong family history, then we have to follow the routine high risk protocols. So how do we do a pre-symptomatic genetic counseling in a patient who is not yet diagnosed with cancer? So we have a daughter of a lady who had breast cancer, uh, uh, and we have found a deleterious mutation in her mother, for example, a BRCA mutation. Again, we have to first find the mutation in the affected patient and then test the similar BRCA mutation in the unaffected daughter. So again, the same protocol continues. We have to inform her regarding what is the chance of picking the mutation. Psychological component is pretty high in this situation, and we have to explain her what if it is positive, what are the influences on her and the family. So positive and negative, what is the risk? If BRCA mutation is absent, then the risk significantly comes down, and you can see uh, uh, the upper diagram where you have a daughter that is uh, we call it as a consultant, the term we give for an unaffected family member, or a family member who is in investigation, we call it as a consultant. So a consultant, if we find that she doesn't have a deleterious mutation, then we keep the black dot outside the circle. If we find a deleterious mutation, but she has not yet manifested disease, then we keep the black dot inside the circle. And this is the if there is no deleterious mutation and the risk is similar to that of the population risk, if there's a deleterious mutation, then her risk significantly increases and the dot comes inside the circle. So what if we have a female patient where a female who comes to you and says that her mother, her grandmother, her siblings, everybody were there, they developed breast and ovarian cancer and all have died. So even in these situations, we can have a multi-gene panel testing where all her relatives have expired due to the disease. So there are certain situations where you have a strong family history of breast ovarian cancer, but you are not finding any mutation among any affected individuals. So if you have not found any deleterious mutation among any of the familial individuals, there is no point doing an extended panel again in the consultant. So instead, we will take it as high risk and we will follow the high risk protocol. So uh, post-test genetic counseling, we have to convey result to the consultant. Consultant is the unaffected individual whose relative has a history of hereditary cancer. So we have to say her about the organ specific risks, what are the prevention strategies, available therapies, risks in offspring, provide counseling and letter to the consultant and to the treating specialist and psychological support. So negative means, is it good news? Yes, it is a good news, but it can be false negative in 10% patients. There can be multigenic inheritance. If it is BRCA1 negative, then her risk is similar to that of the normal population, whereas if it is CHEK2 negative, it doesn't mean that the risk is not there. Still the risk is there. It is higher than the familial risk. So that is about genetic testing and its details. And then coming on to the precision medicine, how practically it is applicable, how complex, how difficult it is in interpretation, and is it really test drive or it is applicable in the real world. This is the set of mutations that we have, very complex to remember each and every mutation, right from the BCR-ABL in CML to the HRD in ovarian cancer. We have drugs, mutations, and targetable drugs. And the list goes on increasing every day. And it is very difficult to remember. So you can see the number of mutations we are picking up is going on. And nearly 16% we are picking up. But there is a gap of giving targeted therapies in around 6%. So there is definitely a gap between what we pick up and what we expose to. So the whole problem is we have a small number of mutations in large number of population and a large number of mutations in small number of population. So we have EGFR ALK mutation, which is a small number of mutation that is there in large number of population, whereas large number of mutation like ROS, MET, BRAF, NTRK. So these are present, these are large number of mutations, they're present in only small number of population. So this is the problem with picking up exact mutations. And for example, you can see the NTRK mutation frequency is nearly 0.0002 to 1.5%. And is it worth it to do testing for all cancers when the incidence is so low or the prevalence is so low? So this is what the transition we are happening from a single gene testing. Now we are testing NGS with multiple genes, finding out right from EGFR ALK, and now we look into MSI and tumor mutation burden. Not only we want to test mutation in the upfront setting, we keep testing whenever there is progression, and we want to see is there a dynamic change in the mutational frequency or the mutation burden, and that becomes cumbersome for a patient. So we look into all the three dimensions. Do I have actionable mutation? If there is actionable mutation, do I have a specific therapy for it, which is actually active? And if it is there, what is the cost of it? So these three-dimensional view of a particular test or a mutation has to be recognized before we put into practice. So whenever we have an NGS report, it has three components. It will give us, is there any targetable mutation or not? And if it is there, what is the level of evidence for it? Are there any resistance markers? Secondly, it gives us, are there any VUS identified? And thirdly, it gives information on MSI, TMB, and HRD. So this is the level of recommendation by ESMO. We have level 1 is standard of care, level 2 is clinical trial or registry preferred option, and so on and so forth. We have level 3 to level 4, 5, and level X, where we can ignore. So now the trend is more towards a molecular tumor board, where you can see clinical oncologist, genetics, bioethics, pathologist, and genomics and informatics all sit together to decide what best can be done to this patient. And this is the discrepancy in the MSKCC. Like we do molecular profile in nearly 86% patients in MSKCC, and actionable mutation is present in 38%, that is nearly half, and we have drugs in only 10%. So we do test for such huge number to find some benefit in 10% patients. Again, the similar thing represented that we pick up mutation and we have specific drugs in a lesser number of population. And this is the community data where you pick up 60 out of the 60 to 70 out of the EGFR ALK mutation, 60 to 70% of them are only getting exposed to the specific drugs, and less than 40% of other genomic alteration other than EGFR ALK get the mass targeted therapy. Again, the similar thing, 14% non-EGFR ALK identified, and only 4.5% received NGS-directed therapies. And this is the problem. Budgetary restrictions, lack of clinical trials, no access to NGS, no access to specific therapies, no molecular tumor boards and others. So there is no need to oversell genomics guided therapies. We have to calibrate the expectations of patients and ourselves, and we have to fulfill the promise of precision medicine. So risk communication finally is extremely important. We have to tell them what is the risk of it, what is the effect on their health and on their family and the social well-being. And just saying the risk bluntly is not the way to go. What we communicate and what the patient understands is different. Just the patient nods the head should not be understood that the patient has understood. And if I say 10% risk, is it high or is it low? The patient doesn't understand whether it is high risk or low risk. So we, instead of putting percentages or rough figures, we have to pictorially represent them and give them simple, like 1 in 3, 3 in 5, instead of saying 20%, 40%, which is difficult to understand. And if we can put a pictorial representation, it will be much easily understandable. And this is the whole risk for genetics, where we have to say, but we must consider presenting only relevant information which the patient can understand and make it easily understandable. And this is the famous Angelina Jolie effect, where she underwent bilateral mastectomy, understanding that her lifetime risk is 87% of developing cancer and 50%, and that's the reason why she underwent such a decision of getting both the breasts operated. But what we need to communicate is, in the initial part of life, the risk is just 6%. Later on, as the time goes, lifetime risk goes up, but in the initial years, it is just 6%. And this is the difference in the perceived and the actual risk. For example, for a heart disease, the perceived risk is so less, but the actual risk is that high. Whereas for a terrorist attack or a bird flu or a COVID, what we think, the perceived risk is so high, but the actual risk is so low. So we have to mix and match, and we have to make them understand the discrepancy in the perceived and the actual risk. So my take-home messages for communication are: use absolute and not relative risk to the patient. Percentages are difficult. We can use simple numbers and simple graphics. And after we tell what the risk of the patient is, we need to understand what the patient has understood and take some feedback from the patient. So these are the tips what we can give to the patient for communication. And with this, I thank you for your patient listening and would be happy to take questions. Thank you.